Hello, this is Dean from Nurse Dean's Learning. I have another tutorial for you, this one about weaning your patient from the ventilator. And maybe the better term here would be liberating them from the ventilator, because we want to free them from this machine that's keeping them back from getting better. Maybe weaning would be more appropriate, talking about a nursing child or something. So this term, liberating, is a newer thing, and maybe the culture of vocabulary in this field will be slow to change, but I'll give it my best try. So how do you decide if your patient is actually able and ready to be freed from their ventilator? First and foremost, please follow your facility policies in regards to weaning from the ventilator. Do not use, or you should not use, the excuse, well, I heard it on YouTube and that's what I'm going to do. Just don't do it. It's better if you just follow what the facility protocols say. But really, the protocol probably says something about, on a daily basis, we should evaluate whether or not this patient should remain on the ventilator, and part of that is giving them a sedation vacation or a sedation holiday. So my guess is somewhere in those protocols it wants you to assess your patient and lift sedation for a given period of time to discuss and assess whether or not this patient is ready to be freed from their ventilator. So what does it mean to lift sedation? It just means we're going to stop the sedation medication, allow it to wear off, let the patient become more alert and oriented, and take part in this trial where we're going to see if they can do okay on their own without having that ventilatory support. And once the sedation has worn off a little bit, the patient is more awake, we're able to conduct a liberation trial, or a weaning trial as most people will call it. This will indicate if the patient is really ready to come off the ventilator or not. So why are we really doing this? Well, the research indicates that a daily sedation vacation and conducting a liberation trial results in fewer ventilator days. Fewer ventilator days results in less number of patients that have ventilator-acquired pneumonia and other complications related to prolonged ventilation. And this, among many other reasons, really results that we want our patients to get better. We want them to improve, be off the ventilator, and on with their lives, being healthy and happy. So does every patient that's on a ventilator get this sedation vacation and liberation trial no matter what? No. Clinical judgment still plays a role here, and there are definitely some people, or patients, that are excluded or exceptions to this rule of doing the liberation trial on a daily basis. The first of these are patients who have an FiO2 of greater than 45%. Clearly their oxygen demand is high enough that being on the ventilator is required. Patients that are hemodynamically unstable, if they have physiological compromise, trauma, whatever, that puts them at a greater risk if they're on lots of vasopressor medications, then clearly they need to remain on the ventilator and continue to recover physiologically and let their cardiovascular system, other organ systems heal, mend, and be able to support their whole body and their functions. So those people are exempt from the daily liberation trial. Generally speaking, though, all of your patients should have an opportunity where we lift their sedation on a daily basis and really decide, does this patient need to continue ventilation therapy with a ventilator? Okay, so once the sedation is lifted, we are ready to begin the first of our testing whether or not this patient can come off the ventilator. And so what we want to do next to begin the liberation trial is a spontaneous breathing test, or we've abbreviated it as SBT. This is done by changing the ventilator settings from AC or pressure support, whatever is going on at that moment. We need to change it just a little bit. Pressure support mode will work okay. This is, you know, that every time they take a breath in, the ventilator gives some prescribed amount of assistance with each breath. This will work out okay. Also, we want our PEEP to be at a relatively low level. Generally, we have that around 5. And maybe tube compensation. This is something that's going to allow the ventilator to compensate for that tube being in place, that extra resistance that's there. The real bottom line here is that the patient receives the minimum amount of assistance from the ventilator as possible for this to be a true trial of their abilities to breathe, to get air in and out, and perfuse. So during the trial, we're going to monitor the patient for about 1 to 3 hours, depending on their condition and the amount of time it takes to really fully assess their abilities. And this will be primarily focused on their response to not having that ventilatory support, not having that ventilator help them to breathe and move air in and out. Once that time period is up, we're going to draw an ABG and see how their blood gases correspond with what we're seeing and assessing them from the outside. The patient should look comfortable. They should be relatively free from anxiety. They should be able to breathe with some sort of normal respiratory rate and depth. But during this time, they may be having some anxiety. It's very scary, especially if they've been ventilated for a long period of time. Be sensitive to that need. Give them encouragement. Understand that this is scary for them, and be there with them during this period of time so that they don't get too scared. It helps reduce their level of anxiety, and really it helps them do better during this trial. We are hoping for a decent blood gas here once we get the results back. We really want our pH to be greater than 7.35. That's a 3. Okay. Our carbon dioxide should be greater than 45. And the PO2, we want it to be in a relatively normal range, say somewhere between the 60 and 70-ish range. Higher is better. That would be great. So if their ABG looks decent here with these values, and they look pretty good, they're not in a considerable amount of distress, then that's a good spontaneous breathing trial. We'd be happy with that. Something else to add to this would be a rapid shallow breathing index, or some people refer to it as a Tobin index. It's named Tobin index because of the Dr. Tobin and his partner Dr. Yang published some results that they found way back in 1991 in the New England Journal of Medicine, where basically they predicted, using this screening process, the likelihood of successful weaning from the patient from the ventilator. So the rapid shallow breathing index, or RSBI, is the respiratory rate in minutes, or number of breaths per minute, divided by the tidal volume, or how deep the patient breathes, measured in liters. So say a patient had a respiratory rate of 20 breaths a minute, and their tidal volume was 500 milliliters. We could express that in liters by 0.5. If we do the simple equation, we end up with 40. Now you can see from this little equation that if your respiration rate, or your breaths per minute, increase, so does the RSBI. That was supposed to be an R. It also goes up. And if your volume decreases, the RSBI also increases. And we don't want that to increase. That would be a bad thing. So an RSBI greater than 105 indicates a poor probability that the patient will successfully be weaned from the ventilator. They will not be able to tolerate breathing without that ventilatory support. So a positive result of the RSBI is that our patient scores less than 105. Another item to consider here is the NIF, or negative inspiratory force. That's how much force the patient can suck in through the tube as they take a deep breath. And the ventilator, you can use that to measure this. We really want them to be somewhere between negative 20 and negative 30 measured in centimeters of water there. At a bare minimum, 20. We'd like to see a little bit higher, but as a minimum, 20. You know, a normal adult will measure out with about 80 to 100. So you can see this is roughly 25% of normal. We don't want it to go any less than that. If they can't take a deep breath in, they will not be able to clear those oral secretions. They will not be able to take enough air in to cough. So this is our base minimum we want to deal with before we move on. Something else to consider is minute ventilation for the patient. This shows that the metabolic demand is low enough that they will not have to breathe too rapidly once they're off the ventilator. It should be less than 15 liters per minute, and that will be a positive indicator, again, that they can tolerate being freed from the ventilator. So for all these numbers that we've discussed and examined thus far help determine the patient's ability to ventilate on their own. Maybe the most important of these is that ABG I mentioned before that is drawn right after their 2 to 3 hours of the spontaneous breathing trial. Now additionally, there are 4 more things that we should consider or as the criteria or the final checklist for liberation. This checklist of sorts is in place to establish whether or not this patient is really ready. Maybe I could use a rocket ship analogy here where NASA at Houston will be conducting a point-by-point checklist prior to the rocket launch. Once all those points are checked, everything's a go, the rocket is prepared for liftoff. So this is maybe our checklist for our patient right before we okay them that they may be lifted off the ventilator. All right, so number 1, the first thing here is basically everything that we've mentioned so far. This includes all of the mechanics of ventilation. We need to be able to answer yes to the fact that all of these things we mentioned are adequate. They successfully completed the SBT, and they have a great looking, or at least a decent looking ABG. We can check that off. And then we move on to number 2. Number 2 is mental status. This has reference to the patient's level of alertness and their ability to protect and maintain their own airway. Now, it doesn't mean that they have to do complex mathematics or higher order thinking, just enough level of alertness that they can be able to be aware of their airway and be able to clear it if they need to. Now, keep in mind, this might have been the reason why they were intubated and placed on the ventilator in the first place. So if it was a consideration to place them on the ventilator, then it definitely is a consideration for us to remove it as well. Check that off. And we'll move on to number 3. If all is well with the mental status, we can give that a check, and then we can move on to the third item. Number 3 is secretions. Now, we have to consider here how much secretions are there in the trachea. How often are we suctioning? Consider all of that, and we have to make a clinical decision based on that information. Are they going to be able to cough that mucus and secretions out? Will they be able to swallow it if necessary? We have to decide if there's just copious amount of secretions, it's just a poor idea to pull out that tube if they're not able to clear those. So we need to decide, is what they're experiencing with secretions, is that going to be okay? Are they going to be able to tolerate that if we remove the tube? If that is the case, we are just one step away from blast off, and that rocket can get off the ground and we can liberate this patient from their ventilator. The last item on our list here is air leak. It might be easiest for me to explain this by using a diagram or some sort of illustration on specifically how the tube sits in the trachea, and it might be easier if we can just take a look at that as I explain it. So here we have our patient with the endotracheal tube inserted, and normally we see here that this balloon or the cuff that's right here is inflated with the edges of that balloon pressed against the wall of the trachea. This is beneficial to us because as it is, it's protecting the airway. We don't see any secretions or stuff getting past it, and as air goes in the tube, it comes out into the lungs like this, and the air doesn't come back out up past that cuff or that balloon on the ET tube. Now, something that might happen while this tube is in place is it's possible that right along this area here, it will get swollen and irritated. And what we want to do with the air leak is we're going to deflate the cuff. And what we want to have happen when we do that is when we insert air into the tube with this cuff deflated, we want the air to leak out past it, and we'll be able to hear that air leaking as it moves past that deflated cuff. If we push air in and we don't hear any air leak, that means that this area here around it is so inflamed that there's still a seal. And that would be bad for us to remove the tube if there's so much swelling there that once the tube's removed, it just closes off and blocks the airway altogether. So when we talk about air leak, what we mean by that is we've deflated the cuff, we push air in, and we're able to hear the air leak back past that deflated cuff. That's a good thing. If we do not hear air pass, then there's too much swelling and we need to leave that tube in place until the swelling can be relieved and the airway won't close off once we pull the tube out. I hope that set up the steps fairly clearly for you. These are a general guideline. They're by no means a guarantee that absolutely nothing bad will happen once you extubate and remove the ventilator from the patient, but it's a pretty good indicator. And the research shows that by doing this, fewer days on the ventilator, patients recover a little bit more quickly, and things move along better for our patients. And maybe one more final consideration I'll throw in here. Maybe it's because I'm a nurse. Maybe I really like the idea of a broad approach, a holistic outlook on our patient. But maybe another thing to consider is their nutrition. And look at the last labs and see if they have adequate amounts of phosphate, magnesium, and albumin in their system to maintain their metabolic needs once we remove the ventilator. Now, the nutrition part isn't necessarily a deal breaker, but it's something to consider. And if we've been able to go through all these things that I've discussed with you, our patient is adequately prepared to check off that final list. Houston can give the go-ahead, and we are ready to liberate our patient from the ventilator. Thank you for watching. I hope it was helpful. I hope it was able to explain some of the steps involved for weaning the patient off of a ventilator, or better yet, liberating them. So if you liked it, please like. And if you think that I can help you with other things, subscribe to the channel. I have other videos and tutorials about different things related to nursing and nursing education. I'd like to help you some more, and feel free to comment. I'd be happy to see what you have to say, and I will try to respond.